Hello future doctors, how are you all? Welcome back to Medsteps YouTube channel. So today we are going to discuss about a very common surgical emergency we can see in accidental emergency department, that is appendicitis. So what it means? Itis means inflammation. So we have in our body we have one structure we call vermiform appendix. Okay, so this is like appendicitis means inflammation or swelling and infection of the appendix. The appendix is a small finger shaped pouch attached to our large intestine on the right side of the abdomen. Okay, so in this video we are going to step by step, like first we are going to discuss about little brief about embryology, then after anatomy, pathogenesis, types of appendicitis, clinical features and some signs and how we can do management, everything, some basic to advanced, everything we are going to discuss in this video. Okay, so without time waste, let's start. So as we discussed before, appendicitis means inflammation of the appendix. Where it's present? It's present in our right side of the abdomen. Okay, if you're seeing this image, you can see here this is the bud, cecal bud of from the cecum at around 6th week of embryological development. You can see here this is cecal bud, and when it's going to develop, that time that cecum, from cecum bud we can see originating of the appendix. Okay, and in down part, in below part, you can see jejunum and ileum loops. Okay, then after when it's going to develop, that time we can see ascending colon and tinea and ileum, cecum and appendix. I will discuss later when we are discussing about importance of surgery. That time this tinea will guide to find out the appendix. Okay, in like peritonitis patients, okay, if you are doing any midline incision, that time we can easily find with help of tinea. Okay, because the tinea will end in down part to near to appendix. That's how you can easily find out appendix to the help of tinea. Okay, so this is the main bud forming on 6th week. This is the important in embryology. Next one, anatomy. So appendix is a narrow and variable length, we can say like 2 to 20 centimeters, and it's attached with posterior medial surface of the cecum. You can see this image. In this image you can see here this appendix, this is the tinea. Okay, I highlighted this thing. So here you can see posterior medial surface, you can see in cecum you can see appendix. Okay, the location will be, it's like terminal end of the cecum where 3 tinea join. So the tinea will join here and some back posterior side and medial side. The tinea will come and it will join, and about 2 centimeters below we can see ileocecal orifice, that means ileocecal valve we can see there. Okay, so the diameter will be, the appendix diameter will be 3 to 8 mm, and the size of the lumen will be 1 to 3 mm like matchstick. Okay, and luminal capacity will be like less than 1 ml. Okay, so here we can see some types of this appendix based on based on some special test we can easily find out the that location and types of the that appendix, means like retrocecal or subcecal, pelvic one, and pre-ileal and post-ileal. We can easily find out based on some special test. We will discuss when we are going to topic. Okay, next one, you can see here mesoappendix. Mesoappendix means it's a extension of the mesentery, contains appendicular artery. You can see here this is some structure, you can see here that these things we can see we call mesenteries. So this is a extension of mesentery, it contains appendicular arteries. So these are the appendicular arteries of caecilium, or we can easily call branch of ileocolic arteries, and it's derived from superior mesenteric arteries. Okay, so this is the tinea, we already discussed this thing. So in this mesoappendix, here we can see some end arteries. This end arteries, because of this end arteries, sometimes the patient will get appendicitis, like maybe it's very tiny capillaries or arteries. So if any thrombosis happen in these vessels, then it will leads to gangrene or gangrenous appendicitis. Okay, so that's why this is very important. Next we can see positions of the appendix. We can the appendix mostly we can see like fixed position with respect to the cecum and end of the various positions. So most commonly we can see the appendix will be retrocecal, because 80% of appendix will be retrocecal, and paracecal, subcecal, pelvic one, subileal, pre-ileal and post-ileal. Based on that direction, we are calling that different position. Based on that position, we are calling this like different types of names of position of the appendix. Okay, so now surgical anatomy. So appendicitis usually happens when something blocks the appendix. Okay, maybe it could be like hardened stool like called fecalith, or swollen lymph tissue, or worms like ascaris. Worms will be like very rare, and tumors like very rare. Okay, so when it gets blocked, bacteria will grow inside and causing swelling, infection and pain. So this is the main thing causing appendicitis. Okay, now surgical anatomy, because I am in general surgery right now, I am doing general surgery department, so that's why I am mostly focusing on surgical anatomy. Okay, so this is appendix. This appendix have some layers like colon layers, like you can see here mucosa. Okay, you can see this appendix part. We zoom this part, you can see cecum and appendix, mesenteries and appendicular arteries. Okay, then after, if you are cross section the appendix part, you can see this type of layers like mucosa and submucosa and inner circular muscle, outer longitudinal muscles and serosa. Okay, inside you can see epithelium, and these are the histology part. Now in submucosal layer we can see some lymph follicles, and it enlarge in response to infection. Whenever you are getting infection, automatically that lymph follicles will enlarge, and we can see swollen of submucosal layer, and it will block the lumen of appendix. Then this condition we call lymph node hyperplasia. So then after it will block, then after we can see ischemic and gangrenous appendicitis. Okay, next, as we know before, as we discussed about appendix, it's a vestigial organ. Vestigial organ means it will help to do immunological organ, like secretes immunoglobulin A. Okay, it will secretes IgA, and it's like acute in acute appendicitis we can see most common acute surgical disease, like mostly we can see in young white males at the peak of lymphoid tissue growth, secondary peak to elderly. Okay, if you are taking fiber rich diet, it will prevent the appendicitis, this type of things, because what I told, this appendicitis caused by something is blocking. What blocking means? Hardened stool called like fecalith, and swollen lymph tissue or worms and tumors. Whenever you are taking more amount of fiber rich diet, so that stool will be not hard, so easily that based on with the movement you can that based on that with movements easily you can see, easily we can prevent that appendicitis and obstruction. Okay, and we can see seasonal variations like May and August will be like epidemic appendicitis based on research. Now causes of appendicitis, mostly it's like idiopathic or unclear, and diet, if we like decreased fiber rich diet are very most common will be like west, but rare in Africa people. Okay, we can see obstruction of lumen with fecalith, hardened stool like small film ball of stool, most common in adults, and it will cause gangrene or perforation, and strictures, tumors and gallstones and foreign body and rounds like threadworms, pinworms, oxyrius vermicularis or adhesions and kinking or carcinoma cecum near the base ileocecal or Crohn's disease. And we can see viral infections also can cause appendicitis, like associated with like mucosal edema and inflammation, and lymphoid hyperplasia with a bacterial infection. And most bacteria like E. coli, like 80% of E. coli can cause appendicitis, enterococci like 30%, and streptococci and anaerobic streptococci and Clostridium welchii and bacterioids. And some pseudo appendicitis also we can say, like due to acute ileitis following like Yersinia infection and often due to Crohn's disease. So now pathogenesis, how this appendicitis will happen, we can divide into two types, like obstructive and non-obstructive. So first we are going to discuss about obstructive causes. Like first of all, because of hard stool or fecalith, most commonly we can, that lumen, I told less than 1 mm lumen will get obstruction. Then after it will leads to increased mucus production and inflammation. The appendix will secrete more amount of mucus and that mucus will obstruct. So then after the fluid will collect inside the lumen because of that obstruction. Then after we can see the distension and increased of intraluminal pressure, and it will leads to blockage of venous and lymphatic drainage. So here whenever that lymphatic drainage and the venous is got blockage, so the bacteria will increase rapidly and it will multiplies. Then after we can see the capillary venule and the pressure, the vascular congestion, and we can see like engorgement. Then after it will impede blood supply like mucosal ischemia and ulceration with ultimate bacterial translocation invasion. The bacteria will spread through submucosa and muscularis propria. Then it's like we can see ischemic involved in serosal surface. The appendicular artery can cause thrombosis. In appendicular artery we can see thrombosis, then after ischemic necrosis, and then after we can see gangrene and perforation of the tip and base of peritonitis. After perforation, the localized by greater momentum and dilated ileum and abscess and appendicular mass, and we can see mucocele of the appendix. So these are the things happening in obstructive appendicitis. Okay, so next one we can see like non-obstructive appendicitis. Here we can see first of all acute inflammation with mucous membrane with secondary infection without obstruction. It will causes like non-obstructive appendicitis. It can like we can see like resolution, fibrosis, recurrent appendicitis, obstructive appendicitis, and gangrene. Gangrene will be rare, and peritonitis and suppression. So we can here we can see like some types of appendicitis. We already discussed obstructive and non-obstructive and recurrent and subacute appendicitis. So first of all, acute obstructive appendicitis. In acute obstructive appendicitis, here first of all the pus will collect inside the blocked lumen of the appendix, which is blackish or gangrenous, edematous, and rapidly progresses leading to perforation either at the tip or at the base of the appendix. This leads to peritonitis and formation of appendicular abscess or pelvic abscess. Most often there will be thrombosis and appendicular artery. So here total 3 things we can see in obstructive appendicitis. Like first one, pus will collect in the inside the lumen. Okay, why? Because of blockage. So here what will happen, that part will get will be like blackish and gangrenous and edematous, and it will lead to perforation. So this is the first condition. Second one, when peritonitis happen, automatic we can say like appendicular abscess or pelvic abscess. Okay, then after if in appendicular artery also if anything got like obstruction or because of thrombosis, it can lead to obstructive appendicitis. Next one we can see here non-obstructive appendicitis. This is cutter hell. Why? How this thing happening means, in mucosal membrane if any inflammation happen, we can see redness edema and hemorrhage, which may result resolution like ulceration, fibrosis, suppurative, recurrent appendicitis like gangrene, it will be very rare, and peritonitis. So next one we can see like recurrent appendicitis, it's like repeated attacks of non-obstructive appendicitis leads to fibrosis and like adhesion causing recurrent appendicitis. Next one, subacute appendicitis is the like milder form of acute appendicitis, and we can see like stump appendicitis is retained long stump of appendix after commonly we can see this thing after commonly like laparoscopic appendectomy. Okay. So now main thing, that is clinical features. With clinical features only we can easily find out the appendicitis and we can diagnose. How? This is very mostly we can see very rare in age of 2 and it's like common in other age groups like 5 to 35 years. And always don't confuse with Murphy's signs. Murphy's sign we can see in acute cholecystitis, and here in appendicitis we can see like Murphy's triad. Murphy's triad means we can see pain in right lower quadrant, then we can see fever, the temperature will increase, pyrexia and nausea and vomiting. Here the earliest pain symptoms will be, you can see like pain around the paraumbilical area. Why that pain you are getting, the patient will get means, we can see that innervation. In this innervation the T10 will be like visceral afferent stretch fibers will be get stimulate, because of that thing we can see visceral pain around the paraumbilical area T10, and we can see pain in a dull like ache or colic because of obstruction in appendiceal lumen. Okay. After few hours we can see right iliac fossa like parietal pain, it's like McBurney point pain, like exit point pain. Okay. And next one we can see the pain will get severe because of the peritoneal cavity and it's spreading. Okay. And with movements also the pain will get, and we can say like with movements patient will get coughing, induced sharp exacerbation of the pain, and vomiting and nausea and vomiting because of pylospasm or reflux. Next one we can see anorexia means loss of appetite, and constipation. In constipation like diarrhea will be, you can see 20%, and most commonly post ileal or pelvic appendix most commonly we can see constipation, these things. And fever will be low grade, and we can see tachycardia and urinary frequency like bladder irritation from contact with inflamed appendix. Okay. So here main thing is, if any patient, any child coming to you with sore throat and flu like symptoms, then after we have to suspect mesenteric adenitis. If any female coming with dysuria or frequency and cloudy, strong and smelling like urine means we have to suspect urinary tract infection, and we have to know the last menstruation period, and we have to know the ectopic pregnancy, and we have to rule out ectopic pregnancy. Okay. Then after, if any patient getting like pain at mid cycle means we have to think about Mettersmark, and if patient getting vaginal discharge something like, then we have to think about pelvic inflammatory diseases. Okay. So what are the signs we can see in appendicitis? First one, tachycardia, mild pyrexia, okay, and greater than 39 degrees. Okay. If any patient have abscess or viral illness, then we can see fever. Okay. And tongue will be like flood, and we can see appendicular abscess or mass, phlegmon, and it's present palpated in the right iliac fossa, and abdominal tenderness like cough with facial expressions. So we have some signs, very important signs, that is we call Blumberg sign, or also known as rebound tenderness. It's like if you are applying pressure on left side, the patient will feel pain on in right side. So because of this thing we call that is rebound tenderness. Okay. So this rebound tenderness most commonly we can see in appendicitis. Okay. So this is the main thing. Next one, pointing sign. If you are asking to show with tip of the finger where you are getting pain, like that, if you are asking to patient, the patient will show that location, that site of pain will be like McBurney pain. That means it's present crossly like umbilicus and ASIS. ASIS we can see like 1/3 part of the McBurney point. The patient will show that area, that site. Okay, and we have some signs, that is Rovsing sign and Soyas sign or obturatory sign. Rovsing sign means if you are palpating in left side, the patient will feel pain in right side, right lower quadrant. Okay, in Soyas sign, if you are trying to flex the knee or flex the hip, then the patient will feel pain. Okay, if you are doing like obturator muscle stimulation, the patient will feel pain like this. You can see in this image. Okay, that leg will be flex, the hip will be flexion, and that patient externally if you are rotating means that patient will feel pain, that then the obturator sign will be positive. Okay, so these are the signs of appendicitis, like Blumberg sign and Tenhan sign, okay, and Bachelor sign or Rovsing sign and Soyas sign, obturator sign. These are this many signs we have to find out appendicitis. Next one, this is the ASIS and this is the pubic symphysis and this is the umbilicus. So in between you can see one triangle, that is the triangle we call Serran's triangle. This is very like hyperesthesia in Serran's triangle. Is very important to do surgeries and these things. And rectal examination should always be done before doing before ruling appendicitis. Rectal exam is always we have to do. Next one, Baldwin sign. So in Baldwin sign it will be like positive when the appendix will be in retrocecal position. When legs are lifted off bed with the knee extended and patient complains of pain while pressing on abdomen, then the Baldwin sign will be positive. And we can see Bested sign. It's like absolute sign in chronic appendicitis. Pain and tenderness is felt in right iliac fossa and inflation of the colon with air. How we can do investigation? So first of all, blood. In lab tests we can see like blood, in blood like full blood count for differential diagnosis. Like leukocyte, we can see leukocytosis greater than 10,000 in 90% of cases, and left shift, that means polymorphonuclear neutrophils predominance will be we can see in left shift. And next one, urinary analysis. In urinary analysis we can see we can rule out with genitourinary pathologies or urinary tract infection. If any blood present in urine or leukocytes, then we have to suspect urinary tract infection. Next one, imaging. Always for appendicitis or appendix, mostly we have to do first of all abdomen X-ray. In abdominal X-ray we can see like clear cut features of acute appendicitis. We can reveal like appendicolith or fecalith less than 15% of cases, and we can indicate like when suspicion of intestinal obstruction or uterocolic. Okay, that time we have to, for ruling out these pathological conditions, we have to do abdominal X-ray. Next one, chest. Like if any air present under the right side of the diaphragm, if any patient have any perforation, then we can see the air under the right side of the diaphragm. So for ruling out that thing, we have to do chest X-ray. Next one, ultrasound. This most commonly ultrasound is the best option because it's very sensitivity, like 85% of sensitivity and 92% of specificity for diagnosis, and we can find we can easily find if that appendix enlarged greater than 6 mm, then we have to suspect that is appendicitis, like hyperechoic and thickened appendix wall because of inflammation, are greater than 2 mm. Okay, and we can see like target sign, like we are mostly focusing on the appendix and appendiceal wall thickening, appendicolith, and we can easily interrupt of submucosal continuity like periappendicular fluid and non-compressible appendix. Okay, so these are the things will help to diagnose the appendicitis, and we can easily with ultrasound we can easily rule out the gynecological pathologies like ureteric stones, pancreatitis, ovarian cyst, rectopregnancy, and for confirmation appendicular mass and abscess we have to do ultrasound. So next one we can do with CT with contrast. Okay, like contrast exposure computerized tomography we can do abdominally, like it's very sensitive, like 95 to 98%. The specific will be 83 to 90%. In several other inflammatory process also we can easily find some things like dilation of appendix to greater than 6 mm in diameter, and we can see thickened appendiceal wall, and it will represents the edema and non-filling of lumen by contrast or air, and we can see periappendiceal streaking and densities within perimesenteric fat, and we can see periappendicular fluid collection, and we can see some presence of appendicolith, and we can see like presence of mass and abscess. So most commonly in reproductive age means we can if female means we can do laparoscopy, like aspiration of cytology, like peritoneal fluid is aspirated using a fine catheter, and we can introduce immediately below the umbilicus. Okay, so if we are suspecting, if gravid means we have to rule out the ectopic pregnancy for female patients. Okay, so here this is the ultrasound. In this ultrasound images you can see here this is the normal proximal appendix part, and here this is the ileocecal wall. Okay, so this is the appendix. So the distal part will be like dilated, this appendix, this is the ileocecal wall. Okay, so this appendix will be like distal segment. So in ultrasound if you are seeing like greater than 6 mm, then and then appendicular wall will be like thick and that lumen increased, and if you are seeing like dilated things, then you have to suspect that is appendicitis. How we can diagnose, how we have to do management means, for appendicitis we have one score that is we call Alvarado score. We have one this Alvarado score will help to diagnose, finalize the appendicitis. So total we have 10 marks. So if less than 5 means we are like not sure, 50-50 chance of appendicitis. 5 to 6 means compatibly, 6 to 9 means probably that is appendicitis, greater than 9 means confirmed. Okay, so we have one mnemonic for Alvarado score, that is MANTRELS, MANTRELS. M means migrating pain. For migrating pain we can give 1 mark. That means migrating pain means that pain will be like radiating from umbilical to right lower quadrant pain near, till ASIS. Okay, A means anorexia, 1 mark. N means nausea and vomiting, 1 mark. T means tenderness in right iliac fossa. So this tenderness in right iliac fossa we can give 2 marks, and we can see like rebound tenderness will be like 1 mark, and elevated temperature will be like 1 mark, and leukocytosis with count like greater than 10,000, then we can give 2 marks, and S means shift to left with neutrophils in peripheral smear. That means polymorphonuclear that cells will be we can see in left shift. If this Alvarado score greater than 9, then we have to confirm the appendicitis. Okay, so now how we can manage this appendicitis means, as we discussed, we have some clinical features with patient. The most common symptom will be like pain, the lower right part of the belly, but it may start near the belly bottom like umbilical, paraumbilically, and then it moves to the right side. Okay, and we can see other symptoms like nausea, vomiting, loss of appetite, fever, constipation or diarrhea. The pain will increase when patient is walking or coughing, or if you are pressing, then the patient will feel more amount of pain. Okay, so first of all, for investigation, physical examination, then after some special tests, then blood test and ultrasound or CT scan, we can do these things. So for treatment is usually surgery to remove the appendix. We called appendectomy. Okay, so before doing management we have to do assessment. So here we have to do resuscitation. We call that is ABC, means we have to check airway, breathing, circulation. So these are the things we have to check. Then after pre-operative assessment, we have to give, if patient is hemodynamically stable, then we have to give some fluids, Unstable means we have to give fluids and some antibiotic, okay, like antibiotic prophylaxis like ciprofloxacin and metronidazole. Okay, in uncomplicated appendicitis or appendectomy, we have some types of incisions like first one, gridiron incision, like perpendicularly to McBurney point. Okay, so it's like grid iron sign. So this is the grid iron sign. Next one we can say Lange crease incision. It's like centering. It's like centering at McBurney point, and cosmetically it will be like very easily we can resolve. So this is the Lange incision. Next one, Rutherford or Morrison's muscle cutting incision. Muscles will cut upward and laterally like this. So this is the Rutherford Morrison's incision. You can see this image. Next one, right lower paramedian incision or lower midline incision. It's like doubt when there is diffuse peritonitis, then we can do this right lower paramedian incision. Okay, next one, laparoscopic approach. In laparoscopic approach, becoming like it's too much mostly nowadays it's mostly popular, and we are going to do this laparoscopic surgeries. Mostly we can do laparoscopic surgeries. Next one, Fowler Ware approach, by cutting muscle medially over the rectus. Okay, so post operative antibiotics mostly we can give for 5 days like metronidazole and cefuroxime, and we can give also some fluids also. Okay, so if bowel sounds are heard and oral diet, if while after post appendectomy, if bowel sounds is positive, then we can start easily oral diet. Okay, and we can start drugs like antibiotics like for 5 days ciprofloxacin and benzyl penicillin, metronidazole, argentamicin, and analgesics. Okay, and appendiceal abscess like CT abscess drainage and development of fecal fistula, and it will heal spontaneously. And we can say like in patient getting like perforation, like we have to do peritoneal washout and peritoneal antibiotics. So what are the troubles we can get while doing appendectomy or after surgery? During surgery appendix is normal, and if during surgery if appendix is normal, then we have to suspect Meckel's diverticulum, the TOOS one, and Crohn's disease or ovarian pelvic like causes, and appendicular tumors. Okay, like carcinoid tumor is most common. Okay, then absence of appendicular is the very rare, and appendicular abscess or pelvic abscess or malignancy. Okay, so these are the things we have to suspect. So what are the differential diagnoses we have in appendicitis? We can divide easily based on conditions like GIT conditions and genitourinary conditions. In children, what are the things we can see with that pain and symptoms with clinical features, like similar clinical features, we can do differential diagnosis. First one, GIT conditions. In GIT conditions we can see like gastroenteritis, mesenteric adenitis, Meckel's diverticulum, interception, typhoid fever, and primary peritonitis. These are the differential diagnosis for GIT conditions. Next one, in genitourinary conditions like ectopic pregnancy, okay, pelvic inflammatory disease, and ovarian torsion, cyst tumors, urinary tract infection, pyelonephritis, ureteral stones. Okay, in children, Meckel's diverticulum, acute colitis, roundworms, colic, and acute iliac lymphadenitis, and interception, lobar pneumonia. Okay, in elder people, diverticulitis and cancer in cecum. Okay, and mesenteric ischemia, intestinal obstruction, aortic aneurysm, and Crohn's disease. In females, like ruptured ectopic pregnancy, ovarian cyst, ovarian abscess, of wooferitis, surpharyngitis, and metastatic. So these are the differential diagnoses we can see. Mostly in general surgery, if the doctor will ask like at least give me 10 differential diagnoses. That time we have to think about conditions, then after we have to try to give reply. Then easily we can, as a medical student, we can easily remember these things. Okay, next one, complication. In complications we can see like paralytic ileus and reactionary hemorrhage due to slipping of ligature, okay, and mostly injured of the surrounding structures and residual abscess and portal pyemia and recurrent intestinal obstruction and right inguinal hernia, like direct one, and wound infections and sepsis and focal fistule, okay, and some like for these things we can do conservative management, and some because of anesthesia we can see some respiratory problems like deep venous prolonged surgery, it can cause deep venous thrombosis, okay, and respiratory problems like atelectasis or pneumonia and aspiration problem. So these are the anesthesia complications. So this is the appendicitis. So I think we covered everything about appendicitis from basic to advanced, okay, so management and everything we covered. So that's all for this video. We will meet in our next video. Till the time, take care. Bye bye.